So it turns out that you were not the last speakers of the day. Someone else pulled that short straw. So please join me in thanking Jennifer and Shelley. And in turning the tide, and we're going to give that award to Amy Miller. So Amy, as you may know, is Executive Vice President of the Personalized Medicine Coalition, which is one of the co-conveners of the Turning the Tide Against Cancer initiative. In her role at the PMC, she works with a broad spectrum of healthcare organizations to reach consensus on policy issues affecting personalized medicine and to advance those policies through direct work with policymakers. Before joining the PMC, Amy worked in the Office of the Director of the National Institute of Mental Health and served as a domestic policy advisor to Senator Jay Rockefeller. So she does indeed have that heroic task of summarizing our discussions from today so we can advance to two things. One, to actionable next steps for the initiative following today's event, and secondly, to the reception. So with that, Amy.
All right, 7 minutes. I think I can do it. Thank you, Marcia, for that very nice introduction. Thank you to the audience for participating today. And I just have to say, it's a tough act to follow, not just the last two speakers, but the entire program. When planning a conference like this, it's very hard to know, frankly, the dynamicism that's going to emerge during the conversations, but I think you'll all agree with me that the speakers were fantastic. So thank you to all of them for a good show. So what is to be done? We've talked a lot about the challenges in cancer care. What is to be done? We have developed the Turning the Tide Against Cancer initiative. And my slides are in a different order on the presentation, so I'm going to go backwards and forwards. Just bear with me here. Here are the three pillars of the Turning the Tide Against Cancer initiative. We talk about defining value, engaging patients, and advancing policy. And we do so through working group meetings, issuing of white papers, and conferences like these. And now I'm going backwards to get to the next slide. The patient-centered cancer ecosystem is composed of all of these different factors, and we talked about many of them today, some more than others, so I'm just going to highlight a few. So we talked about a lot of changes in clinical care. We talked about how iSpy, a program we covered 2 years ago at our national conference, has shown the community some things that work and some things that don't, and now we have LungMap. I really like the LungMap program. I think it will be fantastic when we have master protocols for all of oncology, and it will be wonderful when the lessons learned from those programs can then move into other areas of clinical care. So I think that we're making great strides in clinical research, but then as we heard from our speakers, we still have great strides to go to still make. We also talked a lot about decision support, and we talked a little bit about decision support tools for physicians as they're making treatment decisions with patients, but we talked a lot about the feedback loop between the patient, the provider, and then back again. So patients have a responsibility to engage in their health care, we heard, and they have a responsibility to tell their physicians what's important to them. Physicians have a responsibility to take those things into consideration and then look back at the patient, say, I looked at your test results, here are some options for you, here are the cost-benefit analysis to what that looks like, and then they make the decisions together. We talked a lot about biomedical research and some challenges we have in that space, including systemic challenges. And we talked about care delivery and how that too is challenged, how there's not a lot of care coordination. And we actually had some brave presenters say, I'm educated, I'm in this space, and still when I was faced or my family member was faced with cancer care, it was daunting. And so we need to think about that as a system. And then Sure enough, we heard Dr. Newcomer, a man I've heard speak many times, say, what we need is good old-fashioned comparative effectiveness research. And as much as I recognize the payer perspective and we absolutely need to address payer concerns, we must remember that good old-fashioned comparative effectiveness research was a design modeled before we knew the molecular underpinnings of much disease and before personalized medicine was changing how we experience healthcare. So now I'm going to forward my slides a couple of times. We talked a lot today about patient-centeredness and what it is. So here's two big buckets of what patient-centeredness is. One is patient engagement, and again, I'll repeat myself, it's about communication. It's about the physician communicating to the patient communicating to the physician, and that loop continuing. If you remember from this morning, Mr. Coelho said, when someone's diagnosed with cancer, they're having an emotional flood, and then the physician is flooding them with information. And then the last speaker just noted, sometimes things are said to patients, but it's not absorbed, so it wasn't said. And I'll elaborate on what the speaker said. It wasn't said the right way, or it wasn't said enough times, or it wasn't said at that moment when the patient could absorb it. So I think when we're talking about patient engagement, we really need to think about that feedback loop and work on that. And not a huge highlight of what we talked about today, but a very important part of patient-centeredness is the health information technology. And I think Dr. Kolodziej said it best when he said, there's a lot of data out there and we're not learning from it. So again, we need that other feedback loop, the data feedback loop. Excuse me. And back to the patient-centeredness concept. When we heard from patients, we got some really good imagery from them. So we heard Ms. House say one of her patients wanted to play the piano until the end. And then we saw Deb on the video, and she said she wanted to make memories with her son. And then we saw Salika say, I want the option to maybe have a family, but I haven't even thought about it yet. So now providing value to patients. I put policy in the center here for a reason, because sometimes we think that once we have good science, good technologies, good stuff, it just gets to the patient. It just gets into clinical care. But I know you're a sophisticated audience, so you know that's not true. What's in the middle? What's between science and the patient? Often it's policy solutions. And frankly, maybe it should be policy with a small p, because some policies are not national government policies, but are payer policies or hospital policies or some other programs. So we've heard from others that we need to incentivize into innovation. We didn't really hear a lot about the regulatory process. We heard a little bit this morning about it, but that too needs to support innovation. And then payers need to be recognized how they see value, and we must have innovative policy solutions in the reimbursement space that allow innovations to move forward. So then on to science. Science is changing how we discover and practice medicine. We call it personalized medicine, understanding why something works for someone and making sure that is supported. We also must, again, understand what value means to the patient. And I am going to read from my notes because Dr. Shilsky made two important points on communication of value. One is that it evolves over time, and two, that it needs to be added to the clinical trial information, because we're not capturing it, we're not learning from it, it's not influencing care, and it needs to. And then if I can quote Linda House, and forgive me if I don't get it quite right, but she expanded on a common definition of value to 5 parts: efficacy, tolerability, overall costs. And remember, Saleka was very clear about part of the cost of her care was driving 4 hours to New York City, driving back, and then ultimately relocating. That's New York City, that's a 4-hour drive, but remember, our country is very, very vast, so I'm guessing there's a lot of travel costs in cancer care. 4 was quality of life, and 5, patient satisfaction. And peppered throughout today was different talks about value. And I think having kind of that broader vision of value, then we can put the scientists on how, or the social scientists, if Raju is still in the room, we had a little chat about those guys earlier, talk about how to make that work for clinical trial and also decision support. And then over to clinical care. It needs to be multi-stakeholder, like we see with Less Test Now, which is an online resource trying to take all the stakeholders in non-small cell lung cancer and make sure they have the information they need. And patient preferences, and I really liked how Dr. Abernathy stated it. She said, we have to remind the doctor that they're taking care of a patient, and they always think that, but they don't always communicate it back. So remember to say, I looked at your chart, and here's the decisions we need to make together. Worth repeating. Now, we issued a brief before this conference that had 13 different policy options because we like that lucky number. It's also nice and round, 13. Just kidding. And as you can see, I'm not going to go through all 13. I know I'm standing between you, a cocktail, and a beautiful view. So I'm only going to highlight 3. I'm not even going to go through all of these. Novel clinical trial designs. I've already spoken a little bit about it, but I think there's a lot of work to do here. And Ed started today by talking about Janet Woodcock, and I would like to just reference her again because Janet Woodcock, a regulator at FDA, said, I can take an N of 1 study. If it's really good data and you convince me with that data, I'm comfortable with an N of 1 study. And that's a very simplistic vision of her concepts of the future of clinical trials, but she's got a lot of vision on the future of clinical trials. So did all of our panelists today, and so do you in the audience. So we need to work on getting some of those novel clinical trial designs integrated into how we discover new modalities of care. And then we need reimbursement that keeps pace with advances in science and technology. I've said it before, and I'll say it again. Reimbursement's a challenge. One of our speakers, and I'm blanking on who said it, said, there's a lot to talk about, and there's a lot that needs to be made in a clinical decision, but we're not paying for doctors to have that talk with patients. And we need to think about altering how we reimburse for care. And there were a lot of challenges in the reimbursement paradigm mentioned today, and so we need to be creative about that. And then finally, how do we facilitate research that best helps decisions be made? I know this one on the screen is about decision support tools, but I think we need to broaden it out a little bit more. We need to talk about how physicians and their patients how they make good decisions and what's needed by that community. So I realize I'm out of time, so I'm going to just cut through these comments. But I do want to end on an upside. We have a call to action. We must, where are we? We must champion the solutions that work for our groups. We must work with the groups we belong to that are education and advocacy organizations, and we have a responsibility to do the education that's right for what we do, and work together towards educating the public. Everyone in healthcare wants to provide the best healthcare available to patients, and patients demand that, and we just need to be creative about how to be there. And finally, I want to just end on a celebratory note. We've made incredible advances in cancer. A few different speakers have spoken about them. Ed started with them. Mr. Castellani reiterated them later in the day, and I'd like to end with them. We've made incredible improvements in cancer care. We're going to continue to make incredible improvements in cancer care, and we just need to make sure that we have a strong, innovative, and creative community to make new innovations, and then we have a responsibility to make sure that patients have access to them. We are a large, multifaceted effort, Turning the Tide Against Cancer, and you see on the screen, turningthetideagainstcancer.org is our website. If you have any ideas on how to move forward, please let us know. And then finally, I want to thank Feinstein Keene Healthcare for their hard work in putting this conference together. I want to thank the American Association for Cancer Research for their partnership in this endeavor, and both of those organizations for being co-conveners of this event. And I'd like to thank Avalier Healthcare for putting the issue brief together. They did have the power of the pen, but they also had the power of the herding cats responsibility. So good job there. And again, thank you all for joining us today. I'd like to now invite you to a reception downstairs. Please join us. Thank you.